Oh, good evening in Asia, good afternoon in Europe, and good morning in the Americas. My name is Savio Wu. It is my pleasure to introduce this distinguished speaker today. First of all, I want to wish everybody a Merry Christmas, Happy Holidays, and a healthy New Year's 2021. This is our last distinguished webinar series of the year, but we have 6 more scheduled through June 2021, so please stay tuned. It's a happy day for me because I can introduce Dr. Zong-Ming Li Zong-Ming. Zong-Ming is not only a good friend, but also a wonderful colleague with me for many years. Dr. Li is a self-made, wonderful life story. He was born in Chongqing and ending up today as the endowed chair professor of orthopedic surgery at the University of Arizona, has a huge research center there now. And he's also professor of bioengineering there. He spent more than 2 decades working on musculoskeletal related problems, particularly related to upper extremity. He's really an expert. He's got many accolades and awards. He's a member of the AIMBE, American Institute of Medical Biomedical Engineering, and is a leader in orthopedic societies, both clinical and research. And he has been a very strong and enthusiastic supporter for the AIMBE since its beginning, of WACBE since the very beginning. And he served as our president from 2013 and 2015. And today we are very fortunate to have him give us a lecture on hand biomechanics and clinical translation. So without further ado, I give you Dr. Zong-Ming Li.
Can I see my screen? Okay.
Yeah, perfect.
Thank you, Dr. Wu, for your introduction. It's very special for me to have you host my webinar personally. Thank you for your mentorship. Without your support and mentoring, I could not be where I am. So I show this picture. It's a holiday time. It's a weekend. Take it easy wherever you are. Take a coffee or whatever drinks. So I would like to start with some special acknowledgement. First, Professor Savio Wu, who has this visionary leadership to establish WACBE, which is a wonderful platform for us to network, to make friends, to exchange ideas and collaborate. And I want to thank our current WACBE leadership, Professor Min Zhang, Professor Ed Guo, and Professor Binmei Fu, for their initiative to have this WACBE webinar series that make us connected and continue to be engaged with science. Thank Alexis for her support of organizing the WACBE webinars. I want to also put up front to acknowledge many researchers ranging from a high school student to graduate student, undergraduate student, postdoc, resident fellows, and many colleagues who have been involved with the research work I'm talking, and the many also many funding agencies without them hard to do research. So though the hand has been a wonder for since ancient time, and it is an object for a lot of thoughts, a lot of research, and from our engineers, to neuroscientists, to psychologists, up to philosophers. So people debate even what for our humanity, how the hand shape our intelligence, our brain. As you can see, the ancient Greek philosopher even debated, say, because of the hand we are intelligent, or because we are intelligent, then we have the very skillful hand. Even Newton was quoted by saying, because of the thumb alarm, make him believe the existence of the God. So it's a bigger topic. So I'm very humbled today to talk about a very specific research work we have been doing from a biomechanics and bioengineering perspective. So three parts I want to briefly talk today. One is carpal tunnel, and the second part about arthritis, and the third part to just briefly reflect about the biomechanical translation. The carpal tunnel is a interesting structure that is composed with ligament and bones, and form this tunnel to allow the flexor tendons, median nerve to slide through when we use our hand. And so unfortunately, because of the crowded carpal tunnel and the median nerve in the inside, and it tended to be compressed. When the median nerve is unhappy, and so it causes a cascade of symptoms like tingling and painful and numbness, and could lose function over time. And it has been a major public health issue, affect a lot of people, 3 to 5%, and a lot of people, 1 out of 4, perhaps that number in the U.S. End up with surgery. So I know some cultures may be more tolerant about the pain, so maybe less operation. But in the U.S., we have almost 500,000 surgeries each year. And for surgery, we have complications. Almost up to half of people have recurrence of symptoms. And some people end up with reoperation. And the cost in the US is up to $2 billion per year. So the surgery, the principle for surgery is simple. If the nerve is compressed, so we can open the carpal tunnel by removing the constraint. So then we can increase the carpal tunnel space. Then the median nerve is decompressed, and then the symptom can be relieved. So this is not surprising when you blow off the roof. So you open up space, and you get more room for the median nerve. So it has been shown that we can increase a lot of carpal area. So, however, so as this the surgical procedure, it causes a lot of post-op complications. It's like you take off bricks from a east wall to fix the west wall. So we all realize that. So hand surgeons constantly challenge the current status, want to find ways to decompress the nerve without the mechanical consequences of the division. So you can see a number of attempts have been made to reconstruct the transverse carpal ligament, try to restore its integrity of the structure. So we started to ask a simple question. Can we increase the carpal tunnel space without transecting the ligament? So I want to show you a few ideas we have been working on. We call innovations. I want to be keep in perspective. There are a lot of things we can do. We are on the top of the iceberg. The innovation one is the radioulnar wrist compression approach. Second, to utilize the muscle ligament interaction. Third one is enzymatic degradation of the ligament, collagenolysis. The number 4, and it's about the brain function, sensorimotor aspect. So the first approach. So we started with the idea to stretch the transverse carpal ligament. So it's a lateral thinking. Right? If the ligament is too tight, so can we elongate it and to make it longer without transecting it? Actually, we have had inventions by surgeons who put balloons into the tunnel during the surgery and stretch it. So we were motivated by those ideas, and we did a cadaveric study to stretch the ligament, just this simple lever system to push the ligament up, so we can observe the change of the carpal tunnel space. So not surprising, so when we applied more and more force, and you can see the carpal arch area increased. The more force, the more increases. However, when we did a more detailed analysis, we calculated the length of the ligament. So the middle figure, you can see the ligament was actually not elongated. And so you see the area increased, but the ligament was not elongated. That actually puzzled us for a while. We thought we made a mistake in calculation, and we did re-examine the data, and it was correct. Then it turned out when you stretch the transverse carpal ligament, the carpal arch width decreased. So that is the geometrical consequences when the width narrow, and then the carpal arch was formed. Then you gain the arch area. So that is it's actually unexpected. The finding was more exciting than what we wanted in the beginning, because you go there to stretch the ligament, and you have to go inside there, and or we have people try to stretch from outside, which is very difficult to do. So you go inside to stretch. That is still a surgical procedure. So now we serendipitously found that you don't need to stretch it. You just make the carpal arch width shorter, and you can effectively increase the carpal tunnel. So it's counterintuitive. It sounds like an expansion of the carpal tunnel by compressing the carpal tunnel. So, but if they show this simple simulation, when the carpal arch width is shortened, so you can see how quickly and how dramatically the carpal arch area is expanded. So that's really become that study, which was not intended for, needed to our subsequent 10 years of work. So that is the idea. Then afterwards is all busy work to understand and the biomechanics and about the optimization, about strategy. So now we have this idea. We say, shorten the carpal arch, and we started to work on cadaver study, and we can control the amount of shortening to the carpal arch width. Then we image the tunnel by ultrasound, so that the data shows the inverse relationship of carpal arch height and carpal arch area with width. Basically, the idea we conform when the arch width shortens and the carpal arch height increases and the carpal arch area increases. Then some other biomechanics question we want to ask, you can shorten it. It's a structure, and by whatever force you can apply. Then we want to understand what's the mobility of the carpal bones. So it's a collection of a lot of carpal bones in the wrist. So we want to understand the motion, mobility, relative motion among individual intercarpal joint. So we identify the three-dimensional motion and to see where we can mobilize the carpal bones. Then we also did some morphological study to understand the relative contribution of the carpal tunnel by the ligament and by the bones. So how much we can gain from the ligament, how much we can impact the carpal tunnel at the bony portion. Then this another study we did. They want to understand the stiffness characteristics of the carpal tunnel. We control the force application at the edge of the carpal bones and perturb it by a robotic arm and with force transducers. So we can understand the coupling motion and force in three-dimensional way. So those are cadaveric studies. Now we wanted to move to human, how the in vivo carpal tunnel behave. So we apply the compression of the carpal tunnel, and then we monitor the carpal arch and the median nerve motion. You can see as we apply force, 10 Newton, 20 Newton. So we can see the carpal arch in the bottom figure increases. Also, we were able to monitor the shape change of the median nerve. The typical observation of carpal tunnel syndrome is when the nerve is compressed, the nerve tends to be flattened. So what you can see when we compress the carpal arch, and the median nerve become relaxed and become rounder. So that's a good sign of decompression of the nerve. So then we start to work on the patient actually suffering. The previous one was normal people. So for patient, you can see the similar effect, and you can see the arch formation and the median nerve restoration of shape. And even move a step further, the common knowledge, we know that when people get carpal tunnel syndrome, their carpal tunnel pressure, the pressure inside the tunnel is elevated. So we want to understand if this strategy can reduce the amount of pressure inside the tunnel. So we went to the operation room, and before the patient surgery, we insert the pressure transducer into the tunnel and then apply the compression to the wrist, so we can observe the pressure drop within the tunnel. So that's all come together. Then some computational study. So we want to further now to optimize the manipulation strategy to see what particular directions we can apply in order to have the least amount of forces to generate the largest benefit. So you can see you do get the different effects with different force directions. So that gives us as some strategy to say how we apply the force, control the direction. So now move to more in vivo study related to patient. So another finding we know from the literature is that when the median nerve is stuck, the nerve doesn't move well. So we want to see if the compression force can improve the mobility of the median nerve. So that we observed that when you compress and the median nerve, then you wiggle the finger, you can see that the median nerve can move better. It's not as constricted. So ultimately, when we do translation research for patient benefit, so we wanted to see if patient feel better, and if they feel less tingling, less pain, and less symptoms. So that's what we are working now to understand the clinical effectiveness of this compression. So we did 16 patients. So with 4 weeks of intervention, can see the patient score of pain and the symptoms and improves over time. So that is the first approach we did. So the second one also related to biomechanics. It's muscle ligament interaction. So we did a biomechanics experimental study to observe what's going on inside the tunnel when we do some hand activity such as forceful pinching. So we found that when the muscle contract by the thumb, then the carpal tunnel, the arch is being pulled up, and then that can interestingly increase the carpal tunnel area. So that motivated us to look at some more carefully in the anatomy to see how the individual muscles of the thumb are attached to the ligament. So this is the quantification of the muscles attachment area, multiple thinner muscles of the thumb. So you can see they occupy a significant amount of the ligament. So its anatomy or dictate the function. And with this muscle attachment, when the muscle pulls, then contract. So structurally, it would deform the ligament and form the carpal arch. So then we just now doing more basic research to understand the individual muscles biomechanic function. Now we control them individually and pull individual muscles to see what would be the biomechanical effect. So this is a computational modeling. So there are a lot of factors can affect the outcome. So the attachment area, the magnitude of force, and also the orientation of the muscles if when you change the posture of the thumb. So we want to understand if there we can find some best amount of forces and the best posture, and to see what would be the most effective way to expand the carpal tunnel. And eventually we wanted to take advantage of this anatomy, muscle ligament interaction to benefit the patient. So it's difficult to ask them to actively, voluntarily move the thumb because they already feel pain of the hand. So our idea is potentially we can use electric stimulation to activate the muscle, then to pull the ligament, then to decompress the median nerve. So that's ongoing. So the next one we wanted to show is Collagenolysis, the project. This was motivated by the current use of collagenase for Dupuytren's disease. So this is a FDA approved drug. So it's routine clinical use to inject collagenase into the tendon nodule. So you can break up the fiber, then you can relieve the constraint. This is quite difficult hand problem because you cannot open the hand, so they can break up the fiber. So that we start. How about injecting this collagenase into the transverse carpal ligament to also break up the collagen type 1 and 3 and the fibers to make the ligament less stiff and to make the structure more compliant and can help the median nerve. So that's what we're doing. So it's it's understandable. You put it into the solution and you pour the ligament. You can see the breakdown over time. So we did some cadaveric study, and so we did some histological study to understand the concentration, the time factors, how that can dissolve the collagen. So we are doing more precision work to have a grade of location, where to inject, how to inject, how long we should wait. So this is a study showing that if we inject to the ligament, then we want to observe the time factor over time, how it is affecting the ligament. So the technical aspect that we have to take care is we want to go back to image the exact same location, so we can have a robot to image all those different locations to quantify their mechanical properties. So that is the more biochemical aspect of ligament management. So we started with the question: can we biomechanically manipulate the carpal tunnel to achieve decompression? So we have carpal arch with lateral muscle ligament interaction and the muscle the ligament elongation by collagenase. So we see the promising results. Potentially, we will have some alternative ways to benefit patient. So it has been a long way. We have find this interesting mechanism to narrow carpal arch, and then we prove the concept. Now we are ongoing with the more basic science study and the clinical study. So our plan is to, in the following years, to have a clinical trial for multi-site. Hopefully, eventually, we'll prove that this is an effective way to treat patient without the need of surgery, or it's complementary for surgical approach. So I do want to add another number 4. This is not really ligament carpal arch expansion, but it's also another mechanism we are trying to take advantage to see if we can help this hand disorder. So to relate to the brain mechanisms. So for the hand, it's so intimately connected to the brain. So it's hard to not to consider the brain as you see the picture. The first impression you see is a huge hand that is represented in the brain. So when the hand get painful, get sensory problems, motor problems, so the brain will respond. So we in our current paradigm of carpal tunnel syndrome, really we consider it as a peripheral disorder, and including ourselves, we did a lot of studies on understanding the hand function, kinematics, pinching, perturbation, and proprioception, and stability, strength. So that's all focused on the hand itself, including the current clinical management, rehabilitation, surgery. So we are dealing with the local problems to relieve the median nerve and then to mobility and to therapy. So we have overlooked about the brain's implication, which may explain the lack of full recovery after even doing surgical treatment. So our idea is to see if you have carpal tunnel syndrome, how that alter the brain's function and the maladaptation. So we are working on some functional MRI mapping. So when we do the finger motion and or sensory stimulation to see how the individual representation of digits altered. So normally we have good control of the fingers. Then when you have anomalies over time, so we cannot control our hand well, and the patient complain about the frequent dropping of object. So that has something to do with the whole nervous system, how we control our hand. So the imaging study, and also we do a behavioral study. And so the biomechanics experiment can be powerful. So we can measure force and response reaction time, and as a way to understand the information process in the cortical area. So just looking at the individualized reaction time and the multiple choice reaction time, we get the inference of the brain's lack of information processing. So that's the carpal tunnel syndrome part. I switch to the next part of the talk, arthritis. So I just moved to University of Arizona. Here we have a long history of arthritic research. So here, Dr. Kent Kuo on the right side is our director. Dr. Woods is a founding director and the department chair of orthopedics here a long time ago. And Dr. John Ruth is our current department chair. So this is the center established by NIH founding almost half century, 50 years ago in the 70s. So it's a long history. It's a wonderful place to do arthritis research. So I apologize. I want to deviate a little bit. So this talk is about the hand, but I want to show something about the shoulder research we did, which is easily applicable to hand and many areas for the musculoskeletal system. So at the end stage of shoulder arthritis, patient end up with total joint replacement. Two types of surgeries now: total shoulder arthroplasty and reverse total shoulder arthroplasty. For the anatomical total shoulder arthroplasty, the main problem is the loosening of the glenoid component, which is common for many implants. Over time, it becomes loose and become painful, and have to do surgery again. So the problem with the reverse total shoulder arthroplasty is so-called scapular lodging. So it's an impingement of the inferior aspect of the glenoid. So then for the first part of the implant loosening, we want to track the motion, which is very small, the micro motion, how you track it in patient over time. So the first question to deal with, because we wanted to use a clinical CT, the first thing we want to make sure that there is a valid method to be able to monitor the implant motion over time. So we did a validation study by it's so regarded as a gold standard Biplanar X-ray. And so we implanted tantalum beads into the implant, so you can track those beads. Then we can compare the kinematics obtained by the X-ray and by the clinical CT. So with that validation, so we can quantify the implant motion migration over time, and pre-surgery and post-surgery CT and follow-up CT. And another aspect we wanted to understand what affected the implant loosening. One factor is the bone quality. So there is a good opportunity when you do the total replacement. You can take a piece of bone and do some imaging analysis and mechanical testing. So then you can monitor the implant motion. So then we can correlate with the bone quality with the implant motion. So there are multiple factors like surgical factors, implant type, and the patient's post-op activities. But the bone quality is likely one of the main factors for the loosening of the implant. Then the second surgical approach is reverse shoulder. So as mentioned, that the scapular lodging is the problem. So Dr. Ionati developed this simulation software, and you can put the different implant with different size and put the implant in different positions, superior, inferior, lateral, medial. Then you can simulate how the impingement occur by moving the glenohumeral joint in flexion extension, internal, external rotation. So you can observe the relative positioning between the implants and between the bone to observe the impingement. And so then you can move things around, so you can optimize, so to have an optimal pre-operative plan. Then we also followed up with patients. So after the total joint replacement, put the markers on their shoulder and measure their kinematics. Then you can now play the kinematics back to the model to predict and to observe the in vivo impingement in the simulated software platform. So the new opportunity for hand related osteoarthritis, I hope that would be in the future we'll have more data to present this area of research. It's our new initiative. There are a lot of problems with the hand arthritis, wrist arthritis. For example, the basal joint of the thumb is a major issue, which is very common in women because of the anatomy and tissue properties. And this joint has a lot of range of motion to allow us to do important function of pinching or position. And this joint has a large amount of force. So it's quite dramatically when you apply the model showing from Dr. An's group at Mayo Clinic showed that 1 Newton force at the fingertip can generate 13 times force at this joint. So this joint has to maintain a very good mobility and stability in order to function well. And if not, so the stress concentration and over time has problems. So current treatment, conservative treatment, and a lot of variation of the surgical treatment, we really don't have a very good solution. Implant doesn't work, and it's a challenging issue. There are a lot of opportunities to study this joint about gender, aging, mechanics, therapy, and the scaphonoid advanced collapse, another issue inside of the wrist because of the ligament injury needed to biomechanical problems and the joint malalignment and the abnormal distribution of force and the instability, and then cause arthritic changes. And another one, scaphoid non-union. So this bone fractures commonly when people fall, and this bone doesn't heal well. So over time, it has bad deformity and arthritic problems. So now move to my last, quickly, a few slides about biomechanical translation. So it's a wonderful time for us bioengineers working in health issues. So here's integration of engineering and medicine. We have a lot of solid, innovative approaches in the engineering field, a lot of tools, mechanical, electrical, industrial, and imaging, computer science. So a lot of great method allow us to apply these tools to solve many clinical problems. That is one way that we contribute a lot as engineers. And on the other direction, so we identify different different problems. Then clinical problems do involve a lot of aspect from tissue to organ and to from biology and neuro and mechanical. So that requires a collaboration with many fields and expertise. So we have overall, I think we have done very well about from applying engineering to problems. And the other way seems very challenging for us, because when we identify problems that require teamwork, a lot of consideration. So give an example of orthopedic problem. So we work together with, we as biomechanists, we can contribute a lot for many mechanically related problems. And we work with clinicians and engineers, imaging and neuro people, biologists, therapists. So, and we are fortunate in orthopedic field. So biomechanics has really played a very good role. And so I use this picture to, I'm biased. Biomechanics has been great I use this picture as my hometown to show my nostalgia. I miss a lot of this places along the Yangtze River. So the idea is, on each side of the river, we talk about one dialect, another dialect on the other side. If we don't communicate, we miss a lot of opportunities. You may just imagine if we have a lot of good Chinese medicine on the left side, and with our health of people, we may not fully benefit those medicine. For the right side, we have some clear issues that can benefit with these resources. And for science, we generate a lot of data, a lot of tools, a lot of research. And here, there other side, we have a lot of clinical problems to wait for us to solve. And just what the Butler said, we need this translation to avoid the valley of death. And I feel biomechanics, at least in orthopedic area, has functioned very powerfully to serve that bridge to translate engineering and basic science for clinical problems. So I think the challenge of our biomechanical research is to communicate with clinicians to identify clinical problems and to ask the good question in biomechanics, which is the hardest. Right? So there are a lot of things we can do. So make sure we are geared our effort towards solving clinical problems. And this is most fitted for me to end my talk. So I'm biased biomechanics, but we have a major Savio Wu translation of biomechanical model established by ASME. So it's to encourage to award the significant work done in bioengineering to translate to clinical problems. So this is my last slide. I know there are many friends in the audience. Sorry I cannot see you in person, but I wish all of you happy and healthy holidays, and keep a high spirit. And we do go through tunnels, and long or short, but every tunnel ends with light. So with that, I thank you very much for your attention.
Okay, great. Zong-Ming, if you can unshare the screen. And let me share the screen. So before we go to the questions, I also want to offer my happy holidays for everyone and attending this webinar. So this is the last webinar of this year. I want to point your attentions to the webinar in the coming years, and please follow us and be able to attend those wonderful webinars planned. And also, I like they're announcing the WACBE World Congress on Bioengineering, and let you know we finally decided to move the Congress to 2022 because we really want to have a chance to have in-person Congress, not a virtual Congress. So watching out for the announcement, and we are very confident we're going to meet in 2022. So now we have a couple of questions, and we'll try to answer as many we can. So first is from Alexandra Costia. Does the collagenesis method lead to increased risk of rupture in the TCL or other hand movement complications on the long term?
Yeah, wonderful question. Certainly that is the major question people ask, the safety of this collagenase application. So if you inject the enzymatic agent into the ligament, it could be overdosed, could totally rupture the ligament, and the collagenase can leak into the carpal tunnel, could have an implication to the synovium and to the tendon and to the ligament. So we just get that's what the question actually asked in our grant, NIH grant. We just got funded for the first step to do some feasibility study, and we're working on an animal model to demonstrate some safety, and we do need to optimize the dosage to make sure we have not too much collagenase or penetrate into different places. And we want to figure out also the stoppage when we want to limit the enzymatic activation. So there's a lot of work certainly on the road to control the delivery and control the enzymatic function. And there are good news that the nerve tissue is refractory to this drug and could be relatively safe. nevertheless, when we talk about translate to patient, we have a tremendous amount of work to do to make sure that it is safe. So it's under our planning. We don't have a lot of data yet, so hopefully in the future to show you for that. Thank you.
I see Professor Bimei Fu unmuted herself. I know she has a question.
Hi, Zong-Ming. It's great talk. So I have a question about, I heard that like the carpal tunnel syndrome occurs like in women, some women, like during menopause. Is it true, or any mechanism for it?
It's very true for the higher prevalence in women. The factor is 4 to 1, 4 times higher in female. And we don't have a good understanding why it is the case. It has potentially has a hormonal aspect, and so have the tunnel issues, and even occupation could be related. And so even pregnancy can cause carpal tunnel syndrome. So it is epidemiological fact that the women is more vulnerable to carpal tunnel syndrome. So we are limited about knowing what are the factors.
Okay.
So you're right.
Thank you.
So we have a question from Andy N. I will say the father of hand biomechanics, Dr. N. Thanks for coming, join us. And he has a question for you. Do you recommend your compression principle to prevent CTS? If so, please demonstrate to us the precise manipulation. Wonderful lecture. Thank you.
Yeah, thank you, Dr. An. Certainly, Dr. An has been very inspirational to us for his knowledge for the hand of biomechanics. I have really learned a lot from Dr. An. So thank you for your stimulating question. So that would be wonderful if we can reach to that level of significance. People even wanted to use biomechanical principle to prevent carpal tunnel syndrome. We're talking about prevention is the best medicine. So, which is actually difficult. People don't seem to pay much attention unless they have problem. So if we can reach to that point, someday if we have which I think could be feasible, since biomechanics is relatively doable, easy to implement, especially for those high-risk people. Let's say that people repetitively, they have to use their hand in such a risk way. And people do a massage at home every evening. So that could help their development with carpal tunnel syndrome. That would be quite exciting for us. We will keep working on that to see if we can make that kind of thing happen. So I would say that would be the next level of our biomechanical accomplishment. Not only treat, but prevent.
The next question is from Zipei Liang. Hi, Zipei. Good to see you. So he was wondering, what could be dream imaging capability you need to better understand and treat carpal tunnel syndrome?
Yeah, Zipei, thank you for the question. Imaging certainly. Actually, I learned this again from Dr. Wu and Dr. An. So for biomechanics, two important directions for future. One is molecular cellular biology, and another one is imaging. So we really we're so very excited about the imaging opportunities. I know Dr. Liang has a very high cutting-edge imaging technique. So if we can benefit that for diagnosis and to understand the etiological mechanism like nerve and tendon and the transverse carpal ligament. And one thing imaging we have applied is which I didn't show, is the shear wave elastograph using ultrasound. And it's a non-invasive, convenient technology. We want to test the hypothesis that the ligament mechanical property change is associated with the development of this problem. And so the ligament tend to become stiffer, thicker, and we can monitor the mechanical properties of that ligament to see if we can have an early diagnosis even before you feel the problem. So that is the imaging we are actively using, not only for our chemical method to monitor the time effects and the collagenous effect, also as a diagnostic method. And another area we are working on, our lab is doing a lot of imaging reconstruction to understand the shape, which is a basic classical method to the bony structure. And we want to also to quantify the potential of the manipulation and to combine the ligament and bone together to do simulation. So we have using the imaging in a perhaps a basic way would be really wonderful to learn from our imaging expert to see what we can benefit to use that for diagnostic. So I see a lot of potential in the future. Now currently the nerve conduction test is very painful. People don't like it. If we have implementable, affordable imaging modality, that could be preferable in patient care, and which a lot of hand surgeons are promoting now.
So the next question is from Huinan Liu. Is there certain hand exercise can reduce the carpal tunnel syndrome?
Yeah, the hand, thanks for that question. So this hand exercise, there are a lot. In the physical therapy field, rehab, so they are doing all sorts of massaging and mobilization and stretching exercise, sprinting. So personally, I'm not a fan for many of the exercises, very empirical. And to our understanding of the carpal tunnel structure and the mechanism, I think some exercise, I think a majority of exercise are not really evidence-based, science-based. Since we do carpal tunnel syndrome, a lot of people actually bring their invention device to my lab to want us to study them and want to ask me to give them some suggestion of improvement principles. I have not seen not of good, really very well established approach for those exercises. So certainly, if you mobilize the nerve, you move around, that certainly help increase the circulation, can be beneficial, but it's very empirical. We don't have good exercise. So our approach here, we are not jumping into the treatment for our idea that quickly yet. I would prefer to have the solid science and the systematic investigation, prove it, then we can really later on make a evidence-based therapy treatment for this problem. So I think that still those exercise could benefit, but we need a lot of understanding how it works, why it works to prove. Otherwise, we just get a lot of out there, and people it can be it's a placebo effect. If you touch the hand, people can feel better. So that's exactly how it works. We need a lot of good science for it.
Great. Thank you, Zong-Ming. I think I take my opportunity to ask the last question. I found out the hand OA is actually very fascinating, right? Because next to knee OA, I think hand OA actually have instances higher than the hip OA. But we really know, if I'm understanding, really know little about hand OA. Not too many people working on the hand OA. And then it's very interesting, where it occurs. And also, a lot of times, if one hand develops certain digits have OA, and then the other hand have high propensity also have OA, and then it's kind of, and then in the locations doesn't sound like a mechanical per se, could be mechanical, but the way it appears, on different fingers, if one finger have it, then the other finger also like to have it, right? So I would like to see your comments how people can move forward for be studying hand OA.
Yeah. Thank you, Dr. Guo. So really, let's discuss more and hope to collaborate. You have been doing research in this bone and related area for a long time. A lot of great knowledge on that. So the hand arthritis, certainly I agree with you, has been under researched. Because we have done a lot of spine and the lower extremity arthritic work. The hand, if you observe a lot of elderly people, right, their hand is so much deformed and very disabling. So even in the international arthritis group, they have a white paper really want to develop or have better research about hand arthritis. So what the hand arthritis, many in two major areas, OA, osteoarthritis, and RA, rheumatoid arthritis. So it's not surprising to observe both sides if it's a systemic disease. So it affects everywhere, both the left and the right hand. And OA for traumatic injury related, local factors, mechanical related, could affect the joint locally. So for the hand OA, so if from our biomechanical perspective, the joint such as it's amazingly that about the joint at the tip of the finger, it's most common for arthritis, that tiny joint, because the surface is small and the force is large. I think it's biomechanically a lot of force stress concentration there. So that is an area we can work on. Perhaps it's less disabling there. But for when you get to the wrist, with the ligament injury, change the mechanics and cause the arthritic change over time. So that's a lot of things we could do for biomechanics related. So of course, you're saying the both side. I don't. It got to be some systemic or related or in whether to both sides. Otherwise, a local ligament injury is local mechanics. So we can do that way. Our place, our director is a rheumatologist, is working a lot about this related bilateral knee and the epidemiologic study and the drug effects on one side and on both sides. So it's a big area and a lot of questions. Yeah, thanks, Ed.
Great. So means thanks for a very fantastic talk, and then that's really a very appropriate for a big band for the end of this year. I think that's all for today, and we wish everybody happy holidays and happy New Year. So we'll see all of you next year. Yeah. So Zong-Ming and Dr. Wu and Bingmei and Minzang. Yeah, thanks very much. So happy New Year. See you.